Can't be.
Sorry, Candy. Oh, I think we lost Candace. Oh, nope, she's muted.
There.
My goodness, this computer is giving me kind of a run for my money this morning. Again, this is Candace Powell, and I have the privilege of being the executive director of the Maine Hospice Council, but also facilitating this amazing gathering of people this morning who are coming together to share some of their vulnerabilities, which some say is an act of great courage. There are many analogies for what we're facing today in our world with our global pandemic. And this gives us an opportunity to listen to some wonderfully experienced, wise, insightful people who can and are willing to share some thoughts that might be extremely helpful to all of you. But at the same time, they want to invite you to be part of this conversation. This is not a didactic presentation. This is a conversation. So please, I hope the speakers, once they are introduced, will welcome questions during their presentation. We have a format we're going to follow, but we're not going to stick rigidly to it. We just want to make sure everyone who wants to speak gets an opportunity to speak in the 3 hours that we have. So once again, I apologize that my video is not working, but I have no control over that this morning. So it probably might spare you a bit. And if we can all just be present for what each other has to say, that I think will be a goal worthy of achieving. On public radio this morning, I heard that this afternoon there's going to be a program on the global pandemic and the collective trauma that many people are experiencing. And some of your speakers will have analogies of that, as will I, when I finish my opening remarks, I would like to pause right now and welcome our colleagues and friends from Alaska. We have several folks from Alaska who are gathering with us on this call, and a grand shout out to them for joining us. This affects everybody everywhere in our world. And I hope other areas of our world are doing everything they can to bring folks together as a community of people to discuss their angst and their fears and their stressors. We care about one another, about the sacrifices of families and healthcare professionals, volunteers, our friends and neighbors. The pandemic has challenged our resilience, tested our patience, wounded our souls, and compounded our grief in ways that may reverberate within us for a very long time to come. To some of us, it has broken our spirits, created divisions or anger. To others, it has forced them to search even more intensely for meaning in what is taking place. We all have stories and life experiences with collective trauma. What we do with it, of course, is another question. None of us on this call has all the answers to anything, but we do have insights that might be valuable to anyone and everyone who is participating. When I worked for many years teaching at the Maine State Prison and running a hospice program, I think I have a story that might be helpful. One of the first things I did as I got to know the men in my classes was to share something with them that they could keep and turn to in times of great stress for themselves. And it was about peace. Peace in our world is sometimes difficult to find. But as I said to my daughter, we don't live in a world without trouble or strife or the absence of chaos. What all of us must do at some point is learn to live in the midst of that chaos by finding a place of calm in our soul and in our heart. And of course, that's much more difficult than a few words on paper. But that's why we come together today. We come together today to say thank you and begin a conversation that will continue beyond today. We know that life will be predictably unpredictable forever. And again, as I said to my daughter, it's not what happens to us, it's how we come together as a community to deal, and as individuals, to deal with what happens to us. So with that, I would love to, and we have many resources that we want to leave you with. So when we wrap up today, I will make sure and share a few of them with you. But right now, I would, before I introduce the speakers formally, and then they can say make additional comments about themselves as they speak, I would like to turn this over to Catherine Randall, who is my wonderful executive assistant, to have her just speak to a few issues of technology for folks that might be struggling right now with how to ask questions on a Zoom call. So Catherine, would you take a couple minutes to do that, please?
Yes, Candace, thank you. Hello, everyone. As Candace said, I'm Catherine Randall. I'm the executive assistant at the Maine Hospice Council. I'm so glad to see so many who have already joined us, and I look forward to more joining. We did have 81 people register, which is super, super good. So as far as the technology piece, I'm speaking to those who may not be familiar with Zoom. To mute yourself, which I ask that you do during the event until you have a question, you move your cursor, the little hand you use with your mouse or your keypad, and you'll see the mute button down in the very bottom left-hand corner. To turn on your video, which we encourage because 70% of communication is body language, and we also just love seeing your little faces. And to do that, it's right beside the mute button down on the bottom left of the window. During the event, you can use the chat, which is in the middle of that same row. It has a little talk bubble, and you'll notice the chat will pop up over on the right, and you can type in the box way down on the bottom. You can talk with everyone. You can click on the arrow drop down box and choose a person in that list if you want to have a private conversation with those people. But remember, if you want to talk to everyone, go back to that drop down box and choose everyone, please. So throughout this event, we do encourage conversation, questions, what have you. If you could please raise your hand to be recognized, that would be appreciated. And that is also down in that bottom toolbar with a little hand signal. And we will call on you when there's an opportunity, because we definitely want to hear your voices. Is there anything anyone has a question about that I have not covered? One thing I want to mention, there will be times where we share material, and when I may highlight a speaker, and when we come back to the full room, if you lose the opportunity to see all these people, if you go up to the very top of your screen on the right-hand side, you'll see a view button, and you'll want to choose the one that has all the little blocks, and that'll bring you back to what's called the gallery, where you see everyone. And Jody, I saw your hand up. Could you unmute yourself?
Yeah, hi. I just can't rename myself.
I will do that for you, Jody.
Thank you.
All set, Catherine?
Yes, I am. I'm just gonna rename Jody, and then I'll probably put myself on mute.
Jody, we'll give you a real name now, my dear.
I was going to say, name me Princess Leia or something.
Yeah.
Mine is coming up with my husband's name, if you could change that too. Glee, G-L-E-E.
All set, Catherine?
Yes, is there anyone else? I think I'm all set then. Thank you.
Wonderful. I'll take the opportunity right now to introduce the speakers in order of their presentations. Dr. James Van Kirk will come first, then Dr. Robert Bach, then Dr. Heather Gregory Martin, and then the Reverend Dr. Bernard Richardson. We are just so fortunate to have all these people investing their time with us today in this amazing conversation. So let's go. So Jim Van Kirk is a longtime friend and colleague. We were blessed to have him in Maine for about 20 years, right, Jim? Yep. He was working for Northern Light, and he was the hospice and palliative care director for Northern Light. And it was just such a treat to meet him and work with him over all those years. But darn him, he decided to go back to his home state of Virginia, and he's now a hospice and palliative care specialist at Winchester Medical Center in Virginia. Jim is a terrific educator. He doesn't like formal introductions, so I'm going to personalize this a little bit. He's just a terrific educator, and in a telephone call we had many weeks ago, we decided that now was the time to pull this workshop together, and Jim wanted to work with some of his colleagues at Northern Light, so here we all are, blessed with one another today. He's a kind, thoughtful, skilled clinician who makes lasting impressions on the patients and families and staff he is privileged to meet and interact with along the way. And I bet Virginia and Winchester Medical Center is so delighted that we gave him up to them reluctantly. And he's doing and going to be doing some wonderful things down in Virginia. Jim has received many awards over the years, and which he's too humble to mention. So you might be interested in speaking to him about that. So because I don't want him to blush with any more formal introduction, I will introduce Dr. Robert Bach, who is a retired surgeon. And he's now in a position of spiritual care associate with Northern Light Healthcare at Eastern Maine Medical Center. But he was previously a general and thoracic surgeon. He has a Master's of Divinity as well from Bangor Theological Seminary. And he's a founder of Partners in Health of Maine, an organization which I always donate to. They do wonderful work abroad and really are focusing on the North Atlantic coast of Nicaragua. Bob has also received some incredible awards, humanitarian awards. And if you knew Bob, you would understand why. The Orden Ruben Dario Humanitarian Award in Nicaragua and the International Humanitarian Award at the ACS Clinical Congress in San Diego. Welcome, Dr. Bach. And he's a poet, by the way, too. So he will share some of his poetry with you today. Dr. Gregory Martin, Gregory Martin hails from Arizona. And Arizona was her launching pad for her academic years at Bates College in Maine. From there, she went into the Peace Corps and then medical school and University of Michigan, and did a fellowship in palliative care at Eastern Maine Medical Center in 2020. She works at EMMC as an emergency room doc, and she is also the hospice medical director for Penobscot County. And not only all of that in her professional life, she cares for and about her aging father right now and supports him, along with raising 4 children. So Heather, I think you have your hands full, my dear, and God love you for taking time to join us. Last but not least, by any stretch of the imagination, and I am so delighted he's now in the state of Maine, is Reverend Dr. Bernard Richardson. He's the head chaplain and director of chaplaincy services at Northern Light Eastern Maine Medical Center. He leads the effort there toward becoming an accredited site for the Association of Clinical Pastoral Education. He is working to develop the Clinical Pastoral Education program at EMMC. He supervises students receiving CPE credits, and he oversees the spiritual care and support offered to patients, families, and staff. Certainly an important role during the times we're facing right now. He has a BS in philosophy and psychology from State University of New York, CPE education level 1-2 plus supervisory education at Yale, New Haven. And he was senior chaplain and CPE educator at Johns Hopkins in Baltimore, as well as student admissions coordinator for their academic medicine division CPE program. So we are just so fortunate to have all of these amazing, amazing people with us today to share some of their wonderful wisdom and insights. I can't thank them enough. So please feel free to jump into the conversation. I don't think any of these speakers will mind you doing that. And we will begin with Dr. Jim Van Kirk. Thank you, Jim.
Great, thank you, Candace. Can everyone hear me all right? Just somebody give me a thumbs up. Great, okay. Candace and I have obviously worked together for years, as she said. I thank her for arranging this 3-hour therapy session for me. She and I have been talking about the stresses, the overwhelming stresses of working through the COVID crisis, which I think has accentuated so many of the stresses that are already in healthcare. And so I'm grateful that we have this session. I want to echo what she's already said. I don't want this to be lectures. I want this to be discussion. I'm going to tell some stories. I hope you will tell your stories. I know that we've kind of set this up in a sequential session. I want to tell you that my plan is to lay out the issues, the problems as I see them as a practitioner in the first part. And then I hope that we actually have plenty of time at the end to talk about tools and solutions and mechanisms that we all use to deal with these. I've learned something new or about something new in the past couple of weeks that I'm finding to be very helpful, but I'm not going to talk about it at the beginning. I want to save that for the end. So my hope is that we'll have plenty of time at the end, hint, hint to the other presenters, to share and talk about things that we have found helpful. So real quickly, let me just go and first, also I want to say that it's great to see so many familiar faces. It's great to be able to participate in this program. The Alaska folks, wow, hats off to you. My sister practices in Anchorage, and I think she's 4 or 5. I don't remember if you guys are 4 or 5 behind us right now, but whatever, it's awfully darned early where you are, and that's wonderful that you're on with us. She's always made it quite clear that I'm never to call her before noon. So let me just quickly go through a summary as I've been thinking about this. I have to tell you also that I'm doing this out of my office at work, and I had to drop my car at the shop this morning. And as I tore through the house to get over to the hospital, I left all my pages of notes that I'd taken for myself. So I'm going to wing it. And I think I remember the points of the issues that I really wanted to go through. But again, conversation. So please don't hesitate to interrupt me, write something in chat, put your hand up, whatever. I think that all of us, and when you talk to people that are applying to medical school or nursing school or therapy school or social work school, people that are deciding to go into these careers, they do it because they want to help others. We do this because our desire is to make others' existences better. And there certainly is altruism involved. And there are certainly many things about our system that can chip away at that and make it very hard to hang on to that. But when you talk to people that are in healthcare, they're for the most part doing it because they want to make the world a better place. I'm going to tell you a story about that happened to me in my internship that was probably the pivotal event in my life that steered me into palliative medicine and hospice medicine. It was December. I'm an old guy, so this was long time ago, back before they had restrictions on hours that house staff worked. So it was my first year of training out of medical school. I was doing the month in the intensive care unit. Back then, we were given 1 day off a month when you were on clinical rotations. That month, December, I was on the intensive care unit rotation. Our shifts were, there were 3 teams between the coronary care units and the medical intensive care unit. And so each team took call every 3rd night. And when you were on call, you were pretty much up all night. So you'd work a 36-hour shift, you'd go home and sleep for 10 or 12 hours. You'd come back and work a full day, and then you'd come back the next day and do the 36 hours again. During that month, I had 2 patients, and I wanted to, that were with me the entire month. And I want to tell you about this one guy. He was in his early to mid 40s. He was a Vietnam veteran. He had lung cancer from the effects of Agent Orange. This was back when they were just figuring out what Agent Orange was and what it had done to people. He had already had a tracheostomy. He was ventilator dependent. We were working very hard, recurrent infections, trying to get him off the ventilator. When I came on service on December 1st, he had already been there for several weeks. So I picked him up as I came on service. I took care of him through the whole month. And it was my last day on service, December 31st, and he was still with us. I knew him well, he knew me well. His wife, they had 2 young children, both under the age of 10. That's all I recall. His wife would be in almost every day. And I remember going in to see him and telling him this was going to be my last day, and a new intern would be coming on the next day to meet him, and they'd be with him for the next month. And he had kind of a distressed look in his face. Just didn't get a real feel for what was going on. And the nurse, who again knew him very well, had worked with him for pretty much the whole month as well. And I was turning to leave the room, and all of a sudden he kind of spasmed or jerked, and immediately blood started spewing out of his trach into the ventilator. And the nurse yelled. I turned around. His cancer had eroded into probably, I'm guessing, his pulmonary artery, but he started shooting blood. And she disconnected the ventilator immediately because the tubing was immediately filled. He immediately went into cardiac arrest. His wife, who was standing at that time at the foot of the bed, grabbed his feet and said, screamed, do something. And we started compressions, and for just a fleeting instant, I saw this look of terror and horror in his eyes. And then they just glazed over. We worked, the code team came, we worked on him for maybe 5 or 10 minutes, very quick. He bled out and died. And it was a horror scene. There was blood everywhere, all over. I was doing the chest compressions at the time. There was blood on the ceiling. There was blood all over the nurse and myself. It was a non-savable situation. And the code team left and his wife left, and the nurse and I were left in the room. And I remember she went over to the edge of the room and just slid down the wall and sank to the floor, tears just going down her face. Frustration, feeling that there was nothing that we could do in that situation, feeling horrible about how this guy's life ended. I didn't know what to do. I was a young trainee. I just went over and sat down beside her, and I didn't know what to say. I didn't know what to do. I was feeling her feelings. I was trying really hard to hang on to my emotions. And Dr. Jerry Davis, who was the director of the medical intensive care unit at the University of Vermont, walked into the room. And he looked down at me and he said, "People shouldn't have to die this way. Do something about it," and left. And I remember thinking, and that really was what started me thinking about end-of-life care and changing things. And I think, again, many of us have similar stories of things that have convinced us to move into hospice care or palliative medicine. We've seen horrible deaths. We know that things can be better. And I think that our desire is to try to help make people's passage out of this world a better one. And so that has been what's kind of, that fella has driven my career over the past 35 years. And I think about him often, and I think about that experience often. What I never anticipated was running into what's happened with COVID. And so I'm just going to summarize again real quickly what I've experienced with the different waves of COVID, and being a provider, a palliative care provider. And the first wave, we saw the frail, the medically frail, the elderly, the people that didn't have the ability to fight it off for the most part. And we saw the suffering of families, and we saw a healthcare system that has continued to be stretched to the limits. Everywhere. We saw the horror stories out in New York City. We've experienced some of those things in our own hospitals where, people were lined up in the hallways, people were in the emergency rooms, waiting for beds. I can't wait to hear Heather talk about her experiences. What changed though, so a couple other things with COVID is the isolation that came for all of us with COVID. For me, I have my interactions with my colleagues at work, but afraid to go out in the community. I am fully vaccinated. I'm boosted. I actually kind of cheated, and I'll fess up right now. I've been double boosted because I had my daughter's wedding this past fall. And so I got an early booster before they were called for, and have just recently reboosted because we have another event coming up. And I'm 6 months out, and I'm working with COVID patients all day, every day. But the isolation that we felt as just people in general, but also as providers, has been horrible. I'm in a new community. I've been here. I'm coming up on my 1-year anniversary of working here in Winchester. Being afraid to go to church, not so much worried about myself and what I might get, but wanting to make sure that I don't give something to other people. And so it's been really challenging for me to deal with the isolation aspect. But the most challenging thing that has happened is with the Delta wave. And I need to share a little bit of the demographics of where I am. Winchester, the city itself, is very liberal. Our mayor is an African-American gay male. But as soon as you get outside of the city limits, we are in a very conservative area of the state, very rural. We are up against very rural part of West Virginia, and our health system pulls from West Virginia. We cover as much West Virginia as we do Virginia. And what we found in demographics is that the Winchester Medical Center and the Carilion Health System, which is in Roanoke Memorial, have been consistently the 2 busiest hospitals with COVID. And busier now since vaccination has started because our 2 areas are also the lowest vaccinated rates in the state of Virginia. And I know that most states have this kind of asynchrony or imbalance. I know that Northern Maine experiences the same problem where vaccination rates are lower. And there are all kinds of different reasons on why people choose not to be vaccinated. Everything from the conspiracy theorists to religious beliefs. And it's gotten to the point, it is part of our medical record. When I open a patient's chart, it says whether the patient's been vaccinated or not. It now says whether they've been boosted or not. I almost wish that wasn't there, and I try hard not to look at it because I don't want that to in any way bias me. I don't think it does. But what happened, and when I started talking to Candace about all of this with Delta was the first wave that happened after vaccination was available to the general public. And what we experienced here is that the people that were making it into our ICU with COVID and ending up on ventilators were all unvaccinated people. I will tell you that in the past 6 months, 5 or 6 months, I have worked almost exclusively in our intensive care units. And we're trying to change that now in our palliative care program because it's been overwhelming stress. And on the one hand, it's very convenient to be working with the same staff and for them to know that I'm the one that's going to be there. On the other hand, it's been really tough for me to continue to work with death after death after death. In this time, I've had 2 patients who have died from COVID who were on ventilators, who were vaccinated, and they both, one was a transplant recipient who was immunosuppressed, and the other was a patient with lymphoma who had received chemotherapy who was also immunosuppressed. Every other patient has been an unvaccinated patient. And the difference with this last round with Delta, number one, that's been frustrating because there's this underlying feeling, you see this suffering, you feel the pain, and you think, you know, if you would have chosen to get the vaccine, perhaps this wouldn't be happening, perhaps. The other thing, though, that we've run into here, and again, I'll be eager to hear from other people, other experiences, is we've run into anger from patients and families, particularly families. And for me, this is something that I've never experienced at this level. Families who accuse us, and I'm saying us because they accuse nursing staff, myself, my team, the intensive care providers, infectious disease providers, who accuse us of not doing our best, of not trying to help their family member, of holding back some unknown treatment because the person's not vaccinated. And so
It's still same.
I'm sorry?
Who's that guy?
Oh, and so that for me has been incredibly difficult to be, you know, I will tell you that I've had many 2 and 3 week stretches of work straight because of being understaffed, being overwhelmed with our patient load, having colleagues that are out sick, out with COVID. And so we've been very stretched to the limits. Our nursing staff, watching them, the state of Virginia, the governor issued a medical emergency proclamation, which basically allowed hospitals to change staffing ratios. It kind of voided all union agreements. There are some hospitals in our state, the staffing ratios for an RN to patient were in most hospitals 5 to 1. So 5 patients per RN out on the general medical floors. There are hospitals now, the Centera system reported a 12 to 1 ratio that they're operating under right now in the Norfolk area. In Winchester, we're at about 7. The intensive care units where it was always 1 to 1 or 2 to 1, many are now at 3 or 4 to 1. And so our staff are being stretched beyond the limits. People are working extra shifts, people are tired. And on top of that, we've had this added pressure of being accused of not caring. And that's been overwhelmingly stressful. I have multiple times, you know, come around the corner and found a nurse in tears. I have myself multiple times had to turn and walk away from a room because I just needed to keep my emotions under control. And so this incredible stress that has been added, I will tell you that with Omicron, we are again in a very bad spot right now. Our hospital, our system has reached its limits again. We aren't seeing anywhere near as much of that this time with Omicron as we did with Delta. And I don't know if all of our conspiracy theorists in the area have already gone through it, and so we're not seeing them now, or if people are just giving up and are resigned. But it has been incredibly difficult to be a provider in this crisis and try to keep coming back to work. I love being a palliative care provider. I was used to always being energized and enthusiastic coming into work. And it's been tough the past couple months, dreading coming into the hospital and being afraid of what the day was going to bring and how was I going to be able to deal with it. I read last couple weeks ago, I watched the Sunday morning, the trumpet show. It's on CBS where they have the beautiful trumpet thing at the beginning. And they were talking about how many people have quit their jobs in 2021 through the COVID crisis. And they started with education, and they were talking about the struggles that education is having. A little bit over 3% of educators have quit, have left, and the stress that that's put schools under. Then they talked about the service industry, restaurants, travel, things like that. And they said that was about 4.5% had left their jobs, and how they were having trouble. Restaurants were having trouble reopening, keeping things going. We all hear about the airlines and their troubles. But then they said, but really the one that's leading the pack is healthcare. And in 2021, according to CBS News, 8.4% of healthcare providers quit. they left their jobs. Not to move somewhere else, they left healthcare. Doctors, nurses, therapists, across the board. And then yesterday when I was driving into work, I was listening to NPR, and they actually said that it was 1 in 5, 20%. Now they included in their numbers police, fire, ambulance, first responders. But 1 in 5, 20% of those people in the United States have said, I can't do it anymore, and walked away. And the thoughts crossed my mind, and that was scary. I don't want to quit my work. I love the work that I do. I find a lot of professional satisfaction, personal satisfaction in what I do. But it's been hard to find a way to continue to slug through this. The overwhelming presence of death, and I know this is going to sound crazy for a palliative care hospice provider to complain about dying patients, because this is what we do. This is who we take care of. My worst day was back in the middle of Delta. I lost 8 patients in one day. This past Tuesday was the first day that I've worked in months, and I can't remember the last time that I didn't lose at least one patient. And it was this little celebration. I went home and had ice cream because I couldn't believe that I'd worked through a day and not lost a single person. And I think that I feel that stress. I know that other doctors are feeling it. I know that the nursing staff are under overwhelming stress. What we do hear about, and I don't want to take away from Bob's talk, but what we do hear about is, burnout. You're burning out. You got to protect against burnout. And I personally find that term to be tremendously offensive. I think burnout it puts the onus on the provider. If you were stronger, you wouldn't burn out. If you took better care of yourself, you wouldn't burn out. I don't think that this is on the shoulders of any of us who are in the trenches. And a couple of years ago, I was introduced to the whole idea of moral injury. And so I definitely view this in the framework of moral injury instead. Moral injury is this idea that people are placed in a setting where they are forced or required to do something that they're not prepared to do or that is against their moral code. And it really initially came out of warfare, soldiers. But it talks about the injury to the soul of people that are working in situations where the system doesn't provide the support, doesn't make it possible for them to function in the way in which their morals call them to. And so I encourage all of you to learn more about moral injury, to think about the stresses in your life and how are they related to moral injury. Resiliency, and Bob's going to talk about that. So again, I don't want to take away from that, but fostering resiliency. Again, I don't fault my healthcare institution. I don't fault anybody. We're in a crisis, and the crisis is not one that any of us have control over, really. I do want to read a poem. Sorry, Bob. This is not one that I wrote, so I am not the poet that Dr. Bach is. But this is something that we shared with our team. One of my teammates brought to our team meeting about a month ago. And this was written by an occupational therapist I think she's in Missouri. She worked in an intensive care unit that was overrun by COVID, dealing with COVID patients. And she wrote this after witnessing the work of primarily the nursing staff, but the other providers who were working in that unit with the COVID patients. And I think this really, this says a lot. So here's the poem. Can't hold your hand through doors of glass. Watch nurses touch you as you pass. It's not just night shift that's up at night, as we all worry that things aren't right. Your lungs are on fire, struggling for air, because someone without a mask just didn't care. Watching you suffer is destroying my heart. We healthcare workers are falling apart. Sorry, I'll take a break. When I get dressed for work, it's not just a job. When I lose another patient, it's in my car that I sob. You see, I am human. I bleed just like you. And with each death that I witness, a part of me dies too. You're someone's grandma, you're someone's son, and people's lives are coming undone. Your body is hurting and my heart it aches as I see the fear that's across your face. I know when I touch you with gloves, but underneath there are hands touching with love. You probably think that you're fighting alone, but at the end of each shift, I'm taking you home. I was amazed when Delta was peaking here. A staff member said to me, I don't want this to sound bad, but you look horrible. And it's the first time that I felt comfortable saying, it was a nurse up in the ICU. And I said, you know, I'm struggling tremendously. I go home, I'm exhausted. I fall asleep the second my head hits the pillow, and I sleep for 4 to 4.5 hours. And I'm awake at that point every night with a nightmare. And then it's a struggle to try to get back to get any more rest. I know some of you were involved in the PTSD conference that we did with the VA hospital a couple years ago. And I talked there and I talked about the PTSD that I have following, I was in a medevac helicopter crash during my residency. We were shot down, I was shot in the shoulder. And I know when I'm reaching the limits of my stress because I start to have what I now call helicopter dreams. And at the peak of Delta, for about a 2-week period, that was my typical nightly event, was sleeping until I was awakened by reliving the helicopter crash. I haven't had those yet with Omicron. I will admit, I'm having nightmares. I wake up, usually they're dreams where somebody is calling for help and I can't do anything. I'm unable to get to them. Sometimes it's one of my kids' voices. Sometimes it's just an anonymous voice. But the stress, I think for all of the healthcare providers is overwhelming. And I want to wrap up now. I don't want to leave us in a depressed state. If anybody else wants to talk about the stress they're feeling, but I do want us to have plenty of time to talk about solutions. You know, I try really hard as best as my fatigue lets me to exercise every day. I try to, some of you know, I play the piano. I try to play as often as I can. Sometimes it means going to the hospital piano in the lobby, which is always empty now because we're closed down to visitors, and playing there for 5 minutes. So I'm trying hard to do self-care. But I do want to save as kind of my little ace up the sleeve, the one tool that I've learned in the past couple weeks to talk about toward the end of this session. And so having said all that, does anybody want to share any of their stories? Are there any comments at this point before we kick it over to Bob?
Jonine?
Yes, Johnny.
Janine, you're muted.
Have to say it's wonderful to see your face. It's a tonic. I just wanted to briefly share, for those of you who don't know me, I'm a longtime hospice volunteer for Northern Light. And our son is a critical care pulmonologist in Clearwater, Florida. What he has been through so mimics what you have shared, Jim. It's really kind of eaten him alive. And Mike and I text him every night he's in the ICU. He's blessed with having time off in the office. But when he's in the ICU, it's never good. and he almost always responds to our text. And he has used the term that he is mentally wounded, which I think falls in line with what you have shared, Jim. And we worry about him tremendously. He's doing everything he can for self-care. He's working hard, trying not to be angry. But the one thing I wanted to share, whenever anyone, and either of us empathize with him, the first thing he says is, don't worry about me, worry about the nurses. I get a break, they don't. And he said, I don't know what more I can do to support them, but my heart breaks for them. So I just wanted to throw that in. I'm so glad you're doing this today for all of us. It's very hard. It's been hard after Christmas, particularly, just living this life that's been thrust upon us. And this will be good. So just briefly, thank you.
Thank you, Johnny. Yeah, you can't add to that. He's in the trenches every moment that he works, and he's right. The one thing that I have found that has been tremendously beneficial here is the incredible partnership I have a closer relationship with the nurses that I work with than I've ever experienced with nursing staff. I've had nurses approach me. A couple weeks ago, I had a nurse actually say, "You look like you need a hug," and give me this beautiful, loving hug. And I thought, we're probably breaking every COVID rule in this hospital, but it was the best medicine I could have received. And it was something that I would have never experienced in my past practices, that nursing staff would care about the medical staff or nurture, And so I think a lot of this has been, in a sense, good, that we now have to care more about each other because we're all in there together.
Jim?
Yes.
What do you think we could do regarding policies within institutions? For years and years and years and years and years, we've had very strict guidelines about such things as, crying openly as a healthcare provider and various things like that. Because we all, I think of babies and failure to thrive. And we fail to thrive when we do not have touch at important moments in our lives. And having said this and continuing to talk about this, I do understand, the ethics behind it. Please don't get me wrong. And there's healthy touch and there's unhealthy touch. But I think because we don't allow a little more of that, and I have so many stories I could tell about that, working with staff who are stressed beyond belief, that they could have benefited from just a hug. Where do you think we need to go with that within our healthcare system?
Well, Candace, at the peak of Delta, or I'm sorry, no, a couple weeks ago at the peak of Omicron here, we had 23% of our nursing staff out. 23% of our nursing staff out.
Mm-hmm.
Oh, I understand why we're not supposed to touch each other and why we're supposed to keep distant. But I think you're absolutely right. I think we have to remember that we're human beings and that we're under incredible stress, and that we need to find safe ways to be able to connect.
Right.
And I don't fault that nurse. What that nurse did for me that day was a great gift, and I'm not the least bit upset. I'm sad, and Bob can attest to this. The palliative care team at Eastern Maine used to be the hug team. you went to work, you hugged each other, or you went out onto the floors, and if anybody's the champion hugger, it's Bob Bach. But it's all different now because, gee, if I hug this person, maybe I give them COVID. If I go to church, maybe I spread COVID to somebody. If I go to the store, I found myself doing my shopping at as early or late as possible so that the store will be more empty, because I figure if I've got a subclinical case, I may give it to somebody.
Yeah.
It's tough. I don't know what the right answer is, Candace. I don't know.
Yeah, I think if I may just share a brief story, I think back years ago, a nurse who came to me, she and her husband had been in a car accident. Their baby had died in the accident. And weeks later, her colleagues were very worried about her. So she made an appointment to sit down and have a conversation with me. And during the course of the conversation, I asked her if there was one thing that had been helpful to her, the hours following this accident and the days following that. And she didn't skip a beat. And she said, I don't even have to think about that. She said, what soothed me and soothed my soul the most was that two nurses came up to me, put their arms around me, one on each side, walked down the hall with me and said simply, we are mothers too. And she said, despite all of the technical information that was being thrown at me, despite all the good intentions of all the healthcare professionals, she said, these two nurses saying simply, we are mothers too, with their arms around my shoulders, soothed my soul at that moment more than anything I could possibly tell you. And I have passed that along because I think that gets to the basic humanity of all of us and what we all need, which is comfort, which is what palliative care is all about, right? So I just think because of all of the issues that we deal with in healthcare and all the ethical concerns, we're actually removing one of the very things that might be the most soothing for us. Yeah.
Right. That the same thing is happening with restricting visitation policies. Hospitals are locking down, and I get it. We were able to identify all kinds of lateral transmission of COVID within our hospital, and so they slammed the doors shut. And it was the outcry from the intensive care unit staff, both nursing and medical, saying this just isn't acceptable. We've got to find a way to at least let one or two family members in. And that led to the restrictions being loosened a little bit. The other thing, Candace, that you bring to, and it's the whole humanity issue. We're taught that we're supposed to be tough, we're supposed to be strong, we're not supposed to display emotion. And yet, and this predates COVID, 4 or 5 years ago, a study was done looking at patient satisfaction with providers, with care that they receive. The number one predictor of patient satisfaction, of positive patient satisfaction, was that the patient felt that their provider cared about them. And the number one predictor of that was if the provider actually shed tears. Now, that doesn't mean that it's okay to break down sobbing and crying at bedside and have to be comforted by the family or the patient. But being trained where don't you ever, shed a tear in front of a patient. Well, it turns out that if you feel that distressed or that upset, or if you just get choked up and you need to take a moment to like I did in the middle of that poem, that actually is something that patients and families, it's it's a wonderful thing for them to experience that their provider cares that much. That
Yeah.
they're that invested. Barbara Sinclair, your hand is up.
Hi, Jim. It's great to see you again.
Hi.
I want to give you a salute because I used to do advanced care directive workshops. And whenever we asked you, you always came and talked about it. So thanks for that in the past. I'm a retired psychologist, and from 89 to 96, I worked in the AIDS clinic at LA County USC Medical Center. So went through a lot of deaths. And thinking of listening to what you were saying today, I in addition to providing services for the patients, I did a support group for the nursing staff. But then I went home and I was all alone. And nobody wanted to hear that I worked with AIDS patients. Nobody. So I wound up turning to my friends in the gay community who were more than willing to welcome me. So what I wanted to just point out is for people who are the caregivers, like the therapists and the doctors, where there's nobody above that, they're going home and they're carrying it all with them, and feeling very isolated. Just an incredible sense of isolation that I felt. So looking out for people, if you see that they are one of those people who are feeling isolated in some way, just sending a little card, a note saying, I see you, I care. That's it.
Trisha, I saw your hand up earlier. Would you like to say something?
So Barbara, thank you. You've led in a little bit to what I want to talk about in the last hour, because I think you're absolutely onto something there. So we'll come back to that, I promise.
I would also add, the other thing that got me through those years is my spirituality was profoundly helpful.
Barbara, when I worked in Botswana with children who were in an AIDS orphanage, many of them had lost 4 or 5 family members. And I know Dr. Richardson's going to speak to the issues of spirituality, as all the speakers will at one point or another. But the children echoed what you just said, because the first child I sat down and had a conversation with when I got there, Botswana had a very high percentage of a high rate of AIDS infection. And she talked about what got her through. And it was her finding meaning for herself in what was happening with her family. And the children used music to get in touch with their spirituality. Jim said he went as a way to care for himself, has been playing the piano. And I think we underestimate in healthcare the power of music for patients. So I just wanted to make sure I said that, because the children at the orphanage in Otse, Botswana, used to use music for everything, for education, for soothing their soul, for learning what they felt they needed to know about themselves.
So if it's okay, why don't we go ahead and Bob, you want to go ahead and jump in? And again, if we can possibly end up with a little bit more than 20 minutes at the end, so that we really can have a more robust discussion, I think that would be great.
So Jim was the best chief I ever had. And to sum up, I would say he cared as much about his coworkers as he did about the patients. So nobody's birthday was ever forgotten. Nobody's. And that is just so unique. And as far as, I'm really not the champion hugger, it's Candace. If you can imagine walking into a classroom at a Maine State Prison and being hugged by 10 of the guests, she was one who taught the men it's okay to hug each other. And I just was trying to think, when I walked through the door of the hospital, there was, I can think of one person who would greet me with a hug, and that was this lady, I won't mention her name, who was in the cleaning department. And it was just such a nice way to start the day. So the first thing I want to say is that the empathy is different from compassion, which you all know. But I have a little poem that shows what compassion is versus empathy. This is called Just a Rabbit. Riding my bike in the early peaceful hours, soaking up the beauty of this island. But then in the middle of the road lay a rabbit crushed. I turned around, picked it up, laid in some soft grass, put some wildflowers on it and its chest, turned around and walked away. So if it was empathy, I would have just kept riding the bike and feeling bad for the rabbit, but compassion is when you do something about it. People generally think that compassion is a one-way street. I like to think of compassion like the tide. It goes out, you give, but then it comes back in. And when it comes back in, you've often made a relationship, made a bond, you feel a sense of healing, you feel good. So, people think generally that you have just a limited amount of compassion, that you have to be careful not to be too compassionate. I hear that all the time, don't get too involved. But in fact, it's a two-way street, and it has its healing qualities. So it's not just a limited amount that we have. As far as burnout, I like the change to moral injury. A couple of years ago, when I was working, I felt completely deleted, and I wrote this on running on empty. So many heads without any hair with very beautiful eyes, all trying to accept the fact that they will have an early demise. Children at the bedside wondering why their mother is so sick, hoping that her doctor and nurse can perform some magic trick. These are the images that have been keeping you awake at night, tossing and turning while trying to forget each one's plight. Again, I saw her vomiting in the basin all through the night, determined to show us she was not going to give up the fight. Another face appears of a patient with ALS, blinking her eyes, failing to get a point across no matter how hard she tries. I saw a cracked, empty vase full of wilted flowers, unable to live, as if compassion had drained itself within me with no more to give. I heard my colleague say, "You definitely need a rest. It takes its toll when you are always trying to do your best." Would you expect a hockey player to skate full tilt the entire game? Perhaps not. Taking a break and compassion fatigue are nearly the same. There was no crack in the vase. It was the flowers that sucked it dry. Take some time to sleep, share your feelings, and maybe even cry. So since I wrote this, I really think there was a crack in the vase. And I think it's not that compassion just sucked dry, but because of all the patience, but that little crack in the vase is the support that we sometimes don't have, like nurses, social workers, chaplains. So I don't think it's as simple as that. I think we can improve on that. So I think, some of the definitions of compassion fatigue are emotional exhaustion, depersonalization, relationships between patients and colleagues become cold and distant, and lack of professional completion, inability to respond to requests. So compassion fatigue implies that compassion is tiring, that doctors have a finite reservoir that becomes depleted with overuse. How many times have I heard this? You get too involved. But it has been shown that compassionate approaches to patients decrease the focus on oneself and may buffer against stress. So again, I think it's part of the system that we got thrown into with so many patients, no breaks, things like this that add to what is total body fatigue. What can we do? Physical well-being is really important, and I think just exercising every day raises your endorphins, and that's always been crucial to me to get that lift early in the morning. I think supportive relationships are really a blessing. And when I worked on palliative care, oh my, everybody was, not only hugged each other, but were concerned about each other. And I was just surrounded by loving people. I think that if we find meaning in what we're doing, I think that really helps. And this can be enhanced through prayer or meditation or spiritual ritual, some of which Bernard will comment on. And talking with others,
Dr.
debriefing.
Bach,
Yeah,
can I interrupt?
yeah.
You have a PowerPoint. Did you want to share that?
That's okay.
Okay,
Yeah.
all right, thank you.
Yeah. So I wrote something on emotion, and actually, I'll read this a little later. Then the negative factors affecting physicians' compassion are that often palliative care physicians or any physicians are expected to manage the social aspect. To have social workers working with you, so you can concentrate really on the emotional and spiritual aspects. I think one negative thing is the anger that Jim talked about. I think that puts us in an incredible position when people are yelling at you for doing everything you can, and I think that's where it's important for the team approach to work with a second provider to help you. Sort of in light of the fact that I'm an ex-hockey player, emeritus, I sort of compared palliative care to a hockey team. And these are a few of the things that are similar. You can't win a game alone. You need to get off the ice when you're tired. You need to sit out longer if still exhausted. You need this is really important. You need a pat on the back by your coach or chief, Jim, or fellow players, colleagues and nurses when you go all out. You need the fellowship of the locker room to bond as a team, or a place to break or debrief. You need a good manager to make sure you have everything you need. Parentheses, social workers, chaplain, nurses. You need a good rink manager so the ice is smooth. Parentheses, administration. Signed Bob, right wing. So some of the institutional factors that make it difficult are the pressure to discharge patients, repeated interruptions, administrative demands, and documentation, or the lack of adequate support, meaning social worker, chaplain, and nurses. Some of the clinical factors that really can be hard mountains to climb are treating people with alcoholism, drug abuse, obesity, dependent personalities, somatization, chronic pain, and anger, which Jim has alluded to. Next is releasing, developing awareness and self-care. And this would include mindfulness meditation. It can be done walking meditation. You can run and meditate. You can even get on a rowing machine and meditate. And it's shown to enhance self-compassion and empathy for others. Reflective writing is another thing that really promotes empathetic engagement in physicians. I think that just taking, just jotting down a few things that you experienced in seeing a patient is helpful. In my old medical school, they're actually having, there's a book they put out and has a picture of a stethoscope on it. And that's not just to listen to the heart. The stethoscope is to listen to the patient's narrative or story. And they put about 100 of these together. And it's really quite amazing, because when I was in medical school, there was no such thing. Facts, facts, facts. And that was it. And then my love is writing poems about patients. It provides meaning. When you're writing the poem, you dig out some facts that are just unbelievable. You meet some woman that looks so frail, and you discover that she used to run, a dump truck and a loader and things like this. And it also provides closure. So several times I've been asked to read the poem at the funeral, and that really is an honor to do. As far as releasing emotions, Jim has touched on this. I think that when you're in the room, sometimes just having a moment of silence and bowing your head in reverence is all that's needed. They feel, the family knows you're processing some sadness, and some form of touch. The chief of surgery I had way back in Michigan said, when you make rounds, touch the patient. You can take their pulse, you can see if they have a fever and touch their brow, stroke their brow. You can feel their calf to see if they have phlebitis. And you might even take a blood pressure sometimes, and that really is sort of a very, almost a quarter of an embrace. And so touch is, I think, so important. Jim has alluded to tears, and I can't tell you the times when I've gotten choked up or paused, and the family notices that right away. They treasure that. Gee, he really cared, they treasure that. And then sometimes you have to have a good cry. And never forget leaving a patient's room and running down to the place where the oncologists do their computer work, busting to the door and just sobbing. And there was a very nice physician there who was very comforting. And it's nice to have a place to go to, and it's nice if you can find a chaplain, somebody that can share that with you. And I remember years ago when we lost a patient on the table from a car accident, and I was beside myself, and the chaplain on duty spent at least over an hour sitting in the cafeteria and releasing my emotions. This poem is called buried emotions. And this was about a missed opportunity to share my grief with the nurses, which would have helped both of us. As I put on my long white coat early in the day, it reminds me that I should behave in a certain way. I walk towards the unit where my patient is going to die. I have become so attached that I worry I might cry. If I were a woman, our culture would say it's okay. But as a male, I am reticent because of what people would say. I should be honest with my feelings that are brewing inside, but they just have to stay there, ferment, and be put aside. She smiled at me like an angel as she took her last breath, knowing that her vibrant soul would be soon released by death. I did everything in my power to hold back the tears, as embarrassment was definitely one of my fears. I put my head down, wrote some orders, and went on my way, unaware that the nurses had feelings they wished to convey. I could have shed some tears, said a prayer, or hugged a nurse, but I didn't, for I had succumbed to a self-inflicted curse. Truly a missed opportunity. So it is incumbent on us to self-monitor, and we should check our emotional temperature, a phrase that I got from Candace. And we should have conversations with entrusted colleagues that you can share your burdens, and you can find somebody from spiritual care to provide insight and comfort. So I think that I've been very fortunate in my working on the palliative care service to be surrounded by loving people. It has been truly a privilege and an honor. Thank you.
Thank you so much, Bob. I certainly appreciate that, your insights and your wisdom, as well as your poetry. Thank you. Thank you. We could take a break here if everybody thinks they need to step away for a few minutes, or we could continue and folks can just step away should they need a break anytime during the rest of the morning. Any thoughts on that, folks?
My bias would be to press on. I would love to, and just people are standing up and stretching and
Okay.
grabbing a little snack. I think that's great. Please feel free to do that. But I would encourage us to, I'm so eager to hear Heather and Bernard.
Absolutely.
Does that include bathroom privileges too?
Sure, Bob. But I also, and again, I want to encourage people, we want to hear your stories, and particularly in the last hour, I really want people, because this is how I learned, I'm going to start out with what I'm trying, but I want to hear other thoughts and ideas from all of you. So please don't be shy about participating.
Thank you, Jim. We shall press on indeed. So next up is our very own Heather Gregory Martin, a physician, an ER physician, and a hospice physician covering Penobscot County. I have not met Heather yet, so I'm looking forward to meeting her on this call today. So welcome, Dr. Gregory Martin. We're just delighted to have you.
Hi, can you hear me okay? Yeah. I don't really have anything prepared, and I have to be really honest. Today has been another one of my days. So I have been listening to some of what everyone's been saying. I'm happy to answer any questions. I'll just say that my experience over the last 2 years has been really remarkable. And I'm still processing all of the things that have happened and experiences I've had. I have worked here in Bangor as an emergency doctor for 5 years, and then I did the fellowship last year. And so I worked with palliative care, both inpatient and outpatient, and was doing some home visits through hospice last year. And then when Dr. Van Kirk left, he opened up an opportunity for me here with the hospice. So I commend everybody for the endurance from trying times. And I was reflecting yesterday evening that everyone's experience has been so different. No one really ever knows what it's like to be in anyone else's shoes. And I thought in how lucky I have been in some ways because even though I had to go to work in an emergency department and take care of people with COVID, I got to go to work with my coworkers and got to talk with them and touch them and sometimes even give them hugs, even though it was COVID, because we'd had a hard day or something bad had happened. And that for me probably has been really important, that I've been able to have all of that like pretty frequent human contact. And some people are so isolated and haven't had that, and how different their experience has been over the last few years than mine. So I just want to point out to everybody that, and I think this has already been said by Dr. Bach a little, that we never know anyone else's life. And so we all have to be kind and compassionate. And keep our hearts open to just knowing that everyone comes from a different place. That's all.
Thank you.
Heather, may I ask you a question? I'm curious to know how things have been. Did you run into, have you personally, or have you heard from colleagues, have you run into the anger of families? Have you had to deal with being accused of not doing your best? Or have you heard that from colleagues? You know, have families that are furious because you won't give ivermectin or hydroxychloroquine, or you don't care about us because we aren't vaccinated. Have you experienced any of that?
Yeah. Oh yeah. A lot of, I mean, in the emergency department, that a lot of times that's beyond the emergency department, some of those frustrations. I think the frustrations that we deal with more frontline from the emergency perspective is that patients aren't allowed in, or visitors aren't allowed in, and that is very hard. And they say, well, I've been with them, but you have COVID and they have COVID probably, then you can't come in, but they don't understand. And I've just started to say, well, visitors are giving our patients COVID. So that anger has been hard. I think more so, I'm not on those front lines. The nurses are dealing with that a lot more, so I don't have that. And I know that it's been hard. I've tried to give our very front colleagues who deal with a lot of those interactions support around that, because it is difficult. I also have tried, even though I myself say it's becoming increasingly hard, I think, to keep our morale for doing like all of this really hard work for people who aren't vaccinated, because the people who are vaccinated really aren't getting that sick. And so people who are not vaccinated and choosing not to be vaccinated are the people that are getting really sick and are coming into the emergency department and are not treating us very well. And it's hard to treat people well when you're not being treated well, who aren't vaccinated and who have the ability to maybe make themselves not so sick. And so that sort of fatigue around that sort of burnout from providers has been very real. It's very real. It's palpable. And we have to continue to sort of be light and know they're still getting the best care. They're getting, and I tell people that, yeah. I don't know if that answered your question.
So I just wanted to say, Heather is unique because no matter how much you pile on top of her, she is there, present in the moment, and will listen. And you just know that she cares. And so whenever I've had a close friend or relative, is Heather on? Is Heather on? And
Yep.
it's, and a couple of times I've won the lottery and you were on and just went all out for a patient. And so it's so nice that you are in the emergency room, which is really the mirror of the that's where a lot of
The work is to come, Dr. Bach. So I think that I have potentially the ability, if I have the endurance, to sort of do the work, but really improve upfront care from the emergency department. So we are, and we're starting some things. The fellowship was really good for the emergency department. I have nursing colleagues that are now sort of making, who this is also important to, are making better efforts to do end of life care in the emergency department, if that's what we're tasked to do, or comfort-based care in the emergency department, if that's what we're tasked to do. We are often 2 times focused on aggressive interventions and doing all of those things. And when we are tasked to do the opposite, we don't always pay the best attention. So I have a new role there as well. And I think that there's a lot of good things to come.
well, your name is written on my chest when they take me to the ER. So thank you.
I wonder if there are any nurses on the call that would like to speak up and respond to any of the remarks that Heather has made. I'd love to hear from some of our nurses.
Everyone's quiet.
They are probably too tired to even speak up.
They're all working with the patient still.
That's right. That they have no time to join a webinar, right? Yeah. Any recommendations, Heather, that you might have? We're going to be talking about that at the end too, but anything right off the top of your head that you would share with your colleagues or with the healthcare system in general?
No, I have 2 things. One, I think that we really need to start trying to figure out how to integrate some face-to-face contact again, and some team building and some gatherings as safely as they can be, knowing that we're all going to have risk going forward in life, right? This virus is going to be with us for years, and it's going to have a higher risk of threat than the flu, but it's going to be here. And so I think as we sort of come out of these 2 years, we really need to focus on getting some team building activities together, some strengthening things as a group, face to face, sharing a meal, whatever. And then I don't know, there's so many books to read and all of the books to read, and not that this is a necessarily uplifting book, but I think it's a book that it's one of the books I've managed to read, which is, I don't have tons of time for book reading right now, but it's easy, and maybe most of you have read it, I don't know, but Atul Gawande, Being Mortal, I think is an excellent, easy book, nice, heartwarming vignettes. You might want to cry, but it gives you a really good understanding of the American healthcare system and how maybe we could do it better. And so that's just, maybe someone needs to have something to read. Atul Gawande, Being Mortal.
Mm-hmm. Yeah.
He's wonderful.
Thank you, Heather. Since you just mentioned resources, I'd love to add some books to that list too, and we'll send these out after the webinar. Brene Brown's book, Atlas of the Heart, I think would be extremely helpful for folks to read. Charlie McKersey, Jim just sent a few of us the book, The Boy, the Mole, the Fox, and the Horse. It's an easy to read book, but there is so much wisdom in it. And a lot of it applies to what we find ourselves dealing with these days. Of course, Viktor Frankl's book, Man's Search for Meaning, which is always, 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 it should be a must read for everybody as far as I'm concerned. Ed Tick's book, Dr. Tick's book, War and the Soul, because we've made several analogies to veterans who are dealing with PTSD. And actually that's where many people are finding themselves or will find themselves diagnosed with and dealing with within our healthcare system. And of course, again, I mentioned the Maine Public Radio segment on this afternoon about collective trauma and in the global pandemic. So that's just a few. But Atlas of the Heart and the book about the fox, the mole, the boy, and the horse are just, I read that fox and the boy and the mole and the horse in about 20 minutes the other night and right before bed. And it was just a lovely, lovely, lovely book to go to sleep on. So thank you, Heather. Any comments in addition right now, Heather?
No.
Okay, let's turn this over to Reverend Dr. Bernard Richardson, whom I'm looking forward to hearing from. So Dr. Richardson, it's all yours.
Good morning. I had to take a minute to figure out how to take myself off of mute. First, let me thank you for the opportunity to share and be a part of this esteemed panel with Dr. V. It's good to see you again, and Dr. Bach, and all of your lovely faces. We're in challenging times. And I think that looking at it from the spiritual aspect, I think the best place to start is to really have an understanding of what spirituality is. And I'm sure most of you have your working understanding of what spirituality is for you. What I find in the workplace, professionally, when we talk about spirituality, most people's mindsets, this is a generalization, but most people's mindset goes to religion. And I think for the benefits of our humanity, looking at spirituality with a broader stroke would be more helpful, because spirituality is more than just religion. It's more than our faith orientations or any particular ritual that we experience in the faith community. Spirituality is how I look at it. Spirituality as how we make meaning making in the world. What gives us purpose? What gives us that oomph when we wake up in the morning? And also that sense of peace and serenity when we lay our heads down at night. During this pandemic, I particularly, just to share a little caveat of myself, I found myself struggling with my own spirituality. And being a person of faith, being a person of the religious world, it was foreign for me. At the onset of the pandemic, I lost about over 20 close friends and family in the first year. The closest one that I lost was my grandmother to COVID. And like Dr. Van Kirk shared, I'm a musician as well. And I have often found myself feeding my own spirituality by playing music. I'm a keyboardist. I played for churches for over 20 years in the course of ministry. But during this pandemic and all that was happening, I found myself, I can't even tell you the last time I touched the keyboard. I found myself feeling disconnected. And that's the reality of grief. That's the reality of what we're faced with. On some levels, on many levels, there can be a disconnect emotionally, mentally, physically. I'm really 26 years old, but I lost all my hair and my beard is gray and things of that nature. But I felt like I was getting old. I found myself even dealing with some depression in isolation, and still having to figure out how to be with patients, how to be with staff, how to be with people in the midst of all that was going on around us. We've heard Dr. Bach talk about compassion fatigue and things of that nature in our institutions. And again, another broad stroke generalizations, but I'm sure we've all heard resiliency talk. And in some of my interactions with staff over the last 2 years, a year and a half or so, I found that we have become resilient fatigued. We hear about our ability to be resilient, our resiliency to bounce back, our resiliency to keep going, and it doesn't really give credence to the fact that we are human, that are having these experiences, that are watching patients that we are caring for die, in our own personal circumferences and families and relationships. Those we're experiencing loss in those areas. And these are things that we carry when we go to work every day, when we go and give our best ditch effort to be with people where they are. And so I found what was helpful for me in moving forward was remembering there's a Jewish theologian by the name of Walter Brueggemann. And he wrote a book some years ago called The Spirituality of the Psalms. And I grew up in the faith tradition where we really only quoted the Psalms, the joyful Psalms, the exuberant ones, the victorious ones. But when I read his book, he talked about the lament of the Psalms, giving voice to our emotions and to what we're feeling. He posits it in a way, he gives these three overarching points. He says we experience orientation, disorientation, and then new orientation. Orientation, disorientation, and new orientation. In orientation, we're already oriented in the world a particular kind of way. We're oriented to our professions. Prior to the events of the pandemic, we were oriented to our work in a particular kind of way. And then boom, this disorientation happens. What do we do in the midst of this disorientation? How do we find hope? How do we find meaning and purpose in the midst of this disorientation? And then he talks about in the disorientation, as we figure out how to work through it, we discover a new orientation. In other words, you never go back to how you were oriented in the beginning. So we'll never go back to normal. It'll be a new normal once this is over, but it'll never go back to what it was. Healthcare will never be what it was. Our work ethic will never be the way it was. How we took care of ourselves in times past might not be the way we develop how to take care of ourselves now. And so I was tasked during the midst of the pandemic from the hospital to figure out a way of caring for our staff. One of the things that I brought up in a leadership meeting was, the letters are good, that the mass mailings we receive and the words of encouragement from, leadership and things like those things are good. But in my development, I've learned that there's 3 ways of engagement, communication engagement. There's a wave, there's a shove, and there's getting in the boat. And the emails and things of that nature were good attempts, but some of those things just really waved at our grief. Just, hey, we're all grieving, but we gotta get back in it. We gotta do what we gotta do. We gotta keep going. We gotta keep moving. Didn't really humanize what we were experiencing or are experiencing. Didn't really give much attention to it. It just gave a wave. Hey, I see your sadness. I see your emotions. Then there's the shove, right? There's the shove. There's the yeah, I see what you're going through, but I need you to do this 1, 2, 3, 4, 5 thing. Just get back to work. That kind of connotation. That's the takeaway on the feeling level from some of the acknowledgement. But ideally, is how do we get into the boat? That's the goal. And I look at this with patient care as well as how I care for staff as well. How do I get into the boat with what they're feeling, with what they're going through, and validate, that's the word I was looking for, validate their humanity. It's okay to not be okay. Let me say that again. It's okay not to be okay with what we're experiencing. The challenge comes in is when we're not okay, and in some way it debilitates us, it paralyzes us, or causes us to be less effective. Or what I've experienced over the last 1.5 years or so is that we become, as caregivers, we become on autopilot. And I see this sometimes in the hospital. It's almost like when you look in the eyes of somebody and they're not really there, but they're doing the work, because again, you're skillfully trained to do what you do. But the body of presence is not there. And I think that's in some ways, that's a way of processing. It can be, because there's a self-preservation there. Sometimes we only have enough emotional intelligence for us to make it through the day. I remember being in a meeting, and a provider, it was a Zoom meeting during the pandemic, and the provider blew up in the course of the meeting. Like, just the response to the dialogue was going on was so outside of his character. He didn't go cursing or anything like that, but it was very aggressive, and it was not like his character. And I after the meeting was over, I sent them an email if we could talk, and I just wanted to check in with them, just wanted to make sure, hey, how you doing? How's everything going? Are you okay? That wasn't like you. And he was just saying, Reverend, I got so much going on. I'm working on the ICU unit of the COVID unit. He said, and I'm preparing myself. I'm preparing a area of my house to isolate it off from my family, to not be able to be around them for 2 weeks or whatever the length of time was. And he said, I got all this going on that I'm preparing and wrapping my head around so that I can do my work, but it's also going to cause me to be estranged from my family and my children. And I just had a moment and I lost it. And again, validating what we're feeling is so helpful. It's okay to be angry. I teach my students that emotions are not good or bad. It's how we carry them out that makes them good or bad, right? We can use our anger sometimes as motivation and fuel for engagement and to do the work that we're called to do. There's anger that that fights injustice. There's anger that motivates one to stand up and say, this is not okay. It's okay to be sad. It's okay, you know, to be disappointed or whatever the feelings that is going on, but just validating that you are a human being having a human experience and what you're feeling is validated. How can we discover what would be helpful for you in the here and now? I've discovered that that's also part of the problem, is that we also, as caregivers, sometimes emotionally we struggle with staying in the moment emotionally. So I'm glad to hear when I hear providers and I hear caregivers share that in the moment with the care that they're providing, they feel some kind of emotional connection, that there is a shedding of a tear, there is the impetus to want to, you know, throw your arms around somebody and give them a hug or what have you, because we do crave connection as humans. So how do we find connection? Oh, let me just dial it back for a minute. So I was tasked to find a way of caring for caregivers. I have some pictures. I don't know if we can share the screen, if I can share the screen, Candace, or not. But if not, you can contact me. I can send you what I did. As a means of ritual, and a means of our staff to be able to take care of themselves during the pandemic, I created a resiliency room for staff during the pandemic.
Dr. Richardson, could I interrupt you and ask Catherine if she could share your pictures?
Sure.
Catherine?
Yes, what I can do is I could make Dr. Richardson the host and then he could share his pictures.
Okay.
Do you know how to do that, Dr. Richardson?
I do.
Okay, then that's what I will do.
Great, thank you.
There you go.
Perfect. Can everybody see that? Or did I share it yet?
I can't see it yet. There we go. Yep.
Okay. So what I did was I created, so when we talk about things that will help us get in touch with our spirituality or things that are meaning making, what I did for our staff was create a resiliency room. And in the resiliency room, there were several different tables that were stations for kind of like a self-care moment. And the idea behind it was that in the work that you're doing every day, that our staff is doing every day, that they'll be able to take a moment to come off the floor, take a moment of respite, and utilize these different stations as a means of self-care. So there was a coloring station. There's a station here with memorial sands. So as they use it, they were taking sand of their particular choice and putting it in a vase that's back there on the table. There was a table of lights, and the lights had different words of encouragement like love, peace, hope, joy, comfort or whatever. And they would just come and, flick the light on and put it back on the table. Of course, we had care notes and other paraphernalia for words of encouragement. And here we have a table with pebbles and a bowl. And there's instructions on how to use each station on each table. With the pebbles and the bowls table, with the water bowl table, was the idea of kind of casting your cares on the water. Whatever you brought to work with you that's resonating with you, that's preoccupying, your mind, or something that you're feeling, you take that pebble and you cast it into the water. And a lot of the staff found these this resiliency room to be very helpful in their day-to-day. And just to give you a sense, we filled 2 vases during the pandemic. Well, I should say during 2020, from the employee usage. And so now we capped it off and we have it on display in the chapel. And about it, new orientation, right? Is how do we continue to build something that's beautiful, even out of this experience that we're having. Let's see, anything else? I think I'm at the end of my presentation, so I can yield the rest of my time to questions and any comments that you might have.
Reverend Richardson, I would love to have you speak to I think it's almost like a plague that a lot of healthcare professionals live under all the time, and that is the incredible expectations that they have of themselves and that other people have of them, to be almost perfect and have all the right answers all the time. And I think that does all of us an injustice. I think the word expectation does us an injustice all by itself, because it's an unrealistic request of people, and it's more of the need of the person that has the expectation than the person that they're pointing the finger at. And do you deal with that with staff a lot and family members? And if so, would you please speak to that?
Sure. Yeah, I do think that's a phenomenon that, there's an expectation to be perfect. There's an expectation to have all the answers. What I found to be helpful, and this is something that I learned that we did at Hopkins, is that we had a support group that went around, that rounded, especially on, you can identify units that have, these kind of challenges, the expectations as well as others. But just being able to kind of talk about and talk through, more of a peer-to-peer kind of a situation where, a peer could say to somebody, that's not realistic. It's different than someone who's not as experienced or has the expertise that you have coming to tell you that, your expectations is off, versus someone who's at your level professionally. So, they created resiliency teams that went throughout the institution that met with different workers and dealt with what their expectations might be, and gave them feedback and even constructive criticism if that was warranted, for people to be able to stay fully present.
Thank you.
Welcome.
I think expectation can be such a burden for people, and it's so unrealistic. So thank you very much.
Yeah, it's almost a setup. It's a setup almost for disappointment.
Right, it is.
Yeah.
It sure is. Even that word alone, we need to spend more time talking about, right?
Absolutely.
I think that's another conference, Candace.
I'm sorry, Jim.
I think that's a whole nother conference. I think that's ingrained in healthcare providers.
Right.
All of them.
Right.
That's what I've heard over and over from the nurses is, I love intensive care medicine, but I did this because I wanted to make people better, and I'm used to making people better, and now we're not.
Right. Right. it's a burden that people carry, and we don't talk about it as much as we need to. I mean, in life in general, but certainly in healthcare. And I think it really is a burden that could be alleviated by a better sense of community and reality. So, but we don't talk about it in healthcare. No.
Absolutely.
And we actually punish people in various ways if they don't live up to our expectations, right? So, yeah.
Yeah. Well, we do that professionally and personally.
We sure do. Amen. Amen.
Are there any questions for me?
That was a wonderful, wonderful presentation, Reverend Richardson. It's nice to meet you for one thing, and your grounded comments, everybody's really, but and your resiliency room, we had several comments in the chat about how much people appreciated that. So thank you.
Oh, I'm happy to share. Thank you very much.
Yeah. Yeah. So
You know,
Jim,
Bernard, something that they're doing here, I love your resiliency room. Love it. We don't have that here. They are trying to have kind of resiliency time on all the units. And one of the things that they have been doing is the coloring. And for me, you know, coloring is something little kids do, but they have been taking enormous. I saw you had a bunch of, you know, single page things, and I've seen those around on the different units, but they've also been taking enormous similar things, you know, sketched out lines to the different units, and particularly in the intensive care units, and they're just putting it down with colored pencils or markers or crayons or whatever in the center of the nursing units. And I have watched, I haven't picked one up yet. I want to find the courage to do that. But I've watched nurses come out of a COVID room and take off all their stuff and walk over without saying a word, and walk over and pick up a pencil and just for 2 minutes color. And then kind of, you know, put it down and go on what they're doing. And so it's not something that somebody's doing for one period of time, but I'm seeing them doing it for little bits and moments throughout their workday. And what we found are some absolutely beautiful, spectacular, I don't know what to call them, works of art. They're hanging in our intensive care units and in our nursing units, and some of them are just beyond gorgeous.
Absolutely.
And kind of a reminder of, you know, this is something that all of us created out of our stress. It's been a really therapeutic thing. So I'm delighted to see that you have the coloring station.
Yeah, absolutely. And one of the other things I failed to mention in the pictures that I shared, if you recall, there were 2 boards up with sticky notes on it. And so the idea was you take a sticky and leave a sticky. And you were leaving an encouraging word for the next person who was going to come and use the room. But as you take a sticky for yourself, you leave one. So that got a lot of usage. People just encouraging one another. And what I appreciated the most about it, it was not just providers, it was just not nurses, but also our EVS staff, the people in the kitchen were utilizing the room, that anybody could utilize this space because we're all collectively having this experience.
Yeah, that's wonderful. Does anybody, are you aware of what some institutions have even before the pandemic for a release of emotion? They're called either screaming rooms or crying rooms. Anybody familiar with that?
Wow.
The first one I saw was in Branford, Connecticut, at the first inpatient hospice unit, and this is back in the day, but they had this room, well appointed, but it was padded. The room was padded so that if somebody wanted to go in there and scream or cry, they could do it without the rest of the facility hearing them. And it was used by family members and it was used by staff. And the stories that they shared with me about the power of just having a place to release the energy that some emotions create, just that ability to release that. Of course, it was monitored somewhat so that if anybody was really in trouble, then there would be someone that could assist them. But it was just a place for family members in their grief to vent. Have any of you on the call, are any of you familiar with that option? Well, okay then.
So Candace, I have to say, the last time when I was in college, during finals week, there would be an on-campus scream. It would usually be every afternoon, evening. I did my undergrad at Duke, and the Carillon would always play at 5. And at 5:30 or 6, there would be the on-campus scream, and anybody who wanted to. And it was fascinating. People would pour out of the library, and people who had come out of a final or who were getting ready to go into one the next day. And there would be hundreds of students out there and just doing this moment of massive scream. That's the last time I saw it. And you know, you brought that back to me. To have a safe place to vent emotion. You know, as adults, we're so ingrained with this idea that we need to just internalize everything.
Oh, we're buttoned up so tightly in healthcare, and it is to our healthcare detriment. And this screaming room, if you will, or crying place, we know, I mean, how many of us on this call, maybe a lot of people wouldn't be willing to admit it, but I will. How many over our lifetime have cried so hard that we fell asleep eventually? Because it helped us release a lot of stress within ourselves. And I've done a lot of reading and research about tears and crying and various releases of emotion. And our body knows how to do it. But the thing is, we do not give each other permission to do it safely. And I find that very sad. So I just wanted to bring that up. That might be something that to some degree or other might want to be considered. Yeah.
So Bernard, I wanted to ask you, have you ever considered having music in the resilience room? Like if I'm really feeling sad, you know, I would look, you know, on and choose Yo-Yo Ma. I think it's that piece on Mission is it's like the violin is weeping, and I really get comfort out of listening to some of those. But I wondered if you ever thought of introducing music that people could choose or something in that room.
Excuse me. We did during the time in 2020 when we did it, where we were located. We were going to do it through the TV because we had the resiliency room set up in one of the family rooms on the floor. So we were going to have the music streamed through the television, but that just exposed a lot of logistical things that just weren't right. So we weren't able to do it. When we did it again in 2021, we were just in a bad location. They moved us into a different location. So it is something that we thought about, maybe having a library for people to self-select. So, you know, if we do it again, you know, it's something that we would definitely incorporate in some way. But the last 2 times that we did it, we didn't have music.
Thank you, Janine, for your patience. Would you like to share?
I would, and that goes right along the line of what I wanted to ask Dr. Richardson. You spoke of Psalms and the lament, and I've often felt that some of the Celtic laments are exactly what I need and want when I'm in a place to want to just let down and cry. And I also co-facilitate our bereavement group, and we very commonly ask people about music. People are often afraid to listen to sad music, but the power of that in helping you release and connect directly, I think goes beyond measure. And I wonder if you could set up something on the internet where people could, you know, with their earbud.
Looks like Janine's video has frozen, folks.
Yeah.
Or audio as well.
Yeah.
Yeah.
Okay.
Janine, if you can hear us, your video and audio are both frozen.
I think we lost her.
Yeah, I think we lost her.
Other questions for any of the speakers, Reverend Richardson and other speakers?
Dr.
Jody.
Richardson,
Yes.
where are you? Not right this minute. Where are you? Where do you work?
I'm in virtual space. I'm at Eastern Maine Medical Center.
In Bangor?
In Bangor, yes.
Great. I'm in Ellsworth. That's
Oh,
close
okay.
enough. We could
Absolutely.
connect.
Absolutely, definitely. Please do.
Thank you. Thank
Yeah.
you.
Information about the speakers is on our website, Jody. Yeah. Heather came on late, so her information didn't get up there, but we can leave it posted for a while longer, Catherine, and you could add Heather's to that too. Yeah.
So Jody, what do you do?
Me?
Yeah.
I'm the executive director of Hospice Volunteers of Hancock County, and we've got several of our volunteers on this program today. I'm so proud of you all. Thank you for being here. This has been great. Thank you very much for all of your sharing.
I have, whoops, sorry,
Oh,
Jim.
I'm sorry. So may I give the little bit of what I've learned recently that's helping me cope with the stress? And then I really, really want to hear from many people on this call to see what your personal tricks are. Because I think I learned this from somebody that I just happened, they said, here, listen to this podcast. It was another nurse. I learn a lot from nurses and social workers, I find. I don't know why they don't have us learning more from them during our training, but anyway. And this is something called practicing gratitude. Mm-hmm. And Bob already mentioned this earlier. He said that, you know, what are things that he needs? What does a provider need? You need gratitude. You need somebody to give you the pat on the back that says you're doing a good job. So gratitude is something that is incredibly important to receive. But on this podcast that I listened, they talked a little bit about that and the power in being able to receive gratitude and how that helps lift anybody. But then they spent the majority of the time talking about the impacts of giving gratitude and the impact on the giver, on the person who is giving the gratitude. And somebody who was way smarter than me, I don't know if it was a psychiatrist or psychologist, but they were talking about when our mindset, when our brain is being thankful, is demonstrating gratitude to another, it's impossible for it to be sad. It's impossible for it to be angry. If you are honestly, truly expressing real gratitude to anyone, it actually puts the giver in a better mental position. And so I've been trying really hard to see how many times every day I can thank people that I pass, whether it's a housekeeper or a dietary aide or a nurse or a therapist or another physician colleague or a member of my team. And so I'm continuously trying to exude gratitude to those around me. And I'm finding that it does change my mindset. It's hard to get down in the dumps about poor me, geez, another 12-hour day, or, another day full of loss, when I'm being thankful for the events that I'm working with. And so I throw that out as a challenge to you. I'd love to hear, maybe the Eckharts or Tricia Kluge or anybody else comment on this who knows more about it than I do. But for the past, this is something I started probably in mid-December. And so far for me as a coping mechanism, it's done more for me than anything else up to this point, battling with this COVID crisis. So I'm going to be quiet now. And again, I want to hear from as many of you as are willing to share.
Well, Jim, this is Trisha. I'll try that because I find that I'm really struggling with compassion fatigue and just not caring anymore at all. And I really hate that I'm feeling like that. But when we were talking about kind of the resiliency fatigue and supporting each other, I feel as a social worker, a lot of that pressure has been put on my shoulders. I've been asked to support the rest of the team from the get-go, but not really feeling like making sure they're okay, checking in with them. How are they feeling? What can we do to support them? But kind of being, as a social worker, being forgotten that maybe we're not okay. It's just assumed that we can manage, we can carry the load, we can support everybody else through that, but no one really checking in with us. Are we okay? Because we're not. We're feeling the weight of everybody, as is everybody on this call. So I really have just felt the compassion fatigue a lot. And then my job is supposed to be to connect emotionally with my patients, with my families, and I'm wearing all kinds of PPE, which I get, but you can't, it makes it so much harder to have a meaningful, loving conversation when you're screaming at people through a respirator and feeling like the powers that be that are dictating what our PPE is at any given moment, which changes, don't understand that. And the heaviness, not only physically the heaviness that it feels on your face and your neck, but the emotional heaviness of what we're wearing. And again, I understand it, I get it, but I'm just so over it. I'm just so over it. And I'm really struggling with that, just not caring anymore. And that's not me. It's not me, but that is what I'm feeling. So that's my way of bringing the room down. Sorry, Jim.
I see that Barbara Sinclair has her hand raised, and then Janine.
What Trisha just said is what I was talking about earlier, that therapists social workers, psychologists, whatever, carry the load. And then there they are. There's no one above them they can go to help them. So it really is a matter, and it goes along with something else that I wanted to mention, which is we're all in fast forward perpetual motion, so that we're never really catching up with ourselves. And we need time to do that. We all need time to catch up with ourselves. So we have to somehow in some way carve out moments like the resiliency room or something else, sitting down with a piece of music, sitting down with a few pages of a good book, but something. When I had the nurses group, they'd say, well, we don't have time. And I'd say, well, everybody has to go to the bathroom. So take 5 minutes in the bathroom and do some slow, deep breathing to catch up with yourself and just be present with yourself and take your own temperature. How are you doing right now? What do you need right now? We can't always meet that need for ourselves right now, but maybe we can note that later on, we do need to take care of this and take care of ourselves some way and have some ideas other than the resiliency room when we go home, maybe that we can take that time and take care of ourselves. And I'm a big proponent of breathing. It really helps. And somebody else mentioned I'm a meditator. Walking meditation is great. It's often just sitting meditation for those of us who are busy people doesn't really work. Our mind is just too busy. But walking meditation can be quite soothing.
So one problem, we don't have enough bathrooms in the hospital.
Hey, Catherine.
Yes, Scott.
Hey, this may or may not help. When I worked in the State House many, many years, we were given an hour for lunch. And after maybe the first week of working at the State House, I found that an hour for lunch was much, much too much time. And what I would do instead is I would eat my lunch and then I would go to my car and I would either listen to music or I'd take a power nap or I would do both those things. And I would do that regularly. And we had some long sessions. We weren't dealing with life and death the way the folks on this session are, but that was helpful to me. I found that time, taking that majority of the time for lunch or half the time that I was allotted to lunch and just getting away, going to my car was a good way to get some private time. So maybe that'll be of help to somebody.
Yeah. Yeah.
What I've shared with you earlier, how the pandemic affected me last year. And what I found to be helpful for myself was kind of going back to my first love. And by that, I mean, I started doing more, well, in my role, I was doing a lot of administrative work, but I started doing more patient care. And of course, you all are doing this on a regular basis. So, that may not necessarily be what your first love is or what about it is your first love. But for me, that kind of sparked my own re-engagement, was to go back and do more bedside visits. So, whatever your orientation is, whatever was your first love that got you into this, whatever it is, kind of find a way of enlivening and lifting that up, and that might help as well.
I'm glad you mentioned that. Reverend Richardson, because I remember when I first started doing clinical work back in the day, at between 2 and 3 every afternoon, we used to go around the hospital, whatever floor we were on, and give back rubs to people and offer folks a drink of something if they could have things by mouth. And during that time of offering a back rub, it was done with every patient, unless somebody didn't want one, routinely every afternoon when you work the afternoon shift. And during that back rub, well, we all know, if those of us who have had a massage or rubbed our child's feet or head or arms or something, we all know how therapeutic it is. And it used to be built into the healthcare routine in hospitals. And of course, that doesn't happen anymore. And so your point is so well taken as far as I'm concerned. That's one of the things I used to love, because it gave us time to learn, because the patient would usually talk a lot during that time. It's like why hairdressers get so much information about from their customers, because their hairdressing, it's some time for a person to sit there and relax and have somebody cut their hair or do their hair. And we've taken a lot of those things away from our routines of wellness and caring for people. And I'm sure there's a lot of folks on this call that remember those days, but I find that very unfortunate.
Janine, you've been waiting for quite a while.
That no problem. I apologize. We seem to have this internet instability problem. So when I was I had a thought for Dr. Richardson. I don't know how much of it came through in regard, going back to music. I was speaking of the power of the lament, the sad song, and the value it has. And I wonder if you could put some music that you think would be applicable for people to allow themselves to feel, put it on a website that the staff could access and simply listen to with their earbuds. They have the privacy then of their own time and place at home and in their car when they can let go. I don't think there's anything that works more than the sad song. I really don't. And I think that's why people are drawn to them, because they allow them to just let it happen. So that was my thought about that. In regard to what we're talking about right now, my husband Mike and I have lost in the last 2 years, not relevant, and we have tried to support, the remaining family, friends of these individuals, and we found ourselves spending sometimes, and I'm not exaggerating, 3 to 4 hours on the phone in phone calls. And we reached a point right after Christmas where we both just said, we can't do another one. We have sort of a schedule of when we call and when we email. We were fried, to be honest with you. And we sort of, then we felt guilty because we hadn't been contacting them. And I think we finally came to the realization that if we take one at a time, if we just focus on this widow, maybe the most recent one, and we call her or we send her regular text and not think about the other 4, that we could deal with it a little more effectively. I found this true in regard to hospice and bereavement, that it can get it becomes like a storm cloud in your head. And if you can take a breath and take them one at a time, and whether, I know in a hospital setting, that's not always so easy, but it seems that ability to focus and not let yourself ping pong around to the atrocities that have befallen us can be centering. So that's what I wanted to share.
Thanks, Jonine. Ann Donovan, you had your hand up for quite a while, my dear.
Hi, what a wonderful way to spend the morning. I was thinking when Trisha was talking that it's been really hard because resources were limited 2.5 years ago, and now they are really limited. And so not having a lot to offer some families, but an ear and sitting down and listening. I am trying really hard on my end to up the value of that. I know as a social worker that's super valuable, but there's also a lot of tough situations and families doing really tough care in their homes because placement isn't possible or nearly impossible, and that they're doing it, and our support is helping that, meaning the team, not the social worker, the whole team. And I am working really hard because this is staying. Not a lot is changing, that I need to sort of redefine the importance of listening, validating, but also for myself. Through this, the gift, unfortunately, also was knowing that I wasn't taking really good care of myself. And so trying to do that. This is my day off. Fridays are my day off, but this was really important for me to do, is be part of this. And then I'll get outside and get some fresh air. But thank you so much, all of you. And listening is the best prescription. And working as a team and remembering, because we don't see our team as much, I'm talking about those of us that go into homes, we don't get to meet and gather anymore, to remind ourselves that it isn't all on us. Plus, we can't change the dynamics of resources being so limited and being angry about that and wanting Susan Collins to follow me for a couple days. But then we can't. So anyways, thank you. This has been wonderful. It's also wonderful to see some very lovely faces.
Ann, it's lovely to see you. Thank you for joining us. Jody. Jody?
May I follow up with while Jody's unmuting?
Yeah, Jody, you're on mute. Yes, Jim.
Can I ask a follow-up from Ann? Because, you know, Trisha, I hear exactly what you're saying. And I think, Ann, I think you're right that it's even tougher for the outpatient setting because you never get together. You're together on a screen like we are right now. And it's wonderful to see familiar faces, but it's different. And the one blessing of the work that I've done in the past year is that I actually get to work with three-dimensional people, colleagues, coworkers. And that has been an incredible gift to me because I was so tired of just seeing people on screens. For me, getting to, that's probably the best part of my work right now, is getting to work with the nurses and the social workers and the colleagues. But Ann, I wanna ask you, you know, I hear Trisha and I hear what she's saying about just having the world on our shoulders. How do we make the team better in looking out for each other and not having the responsibility? I mean, I worked with Trisha Kluge for a long time, and Trisha's an amazing social worker. And I learned so much from her, and I admire and respect her so much. But what I hear her just say is terrifying to me, because I hear somebody who's ready to say, I'm done. And I know how scary that is, because that's where I was a couple months ago. I was ready to just say, forget it. I'm ready to go be a farmer for the rest of my life. I'll live on the family farm, and I'll worry about, you know, when the tractor needs to get its next oil change. And I don't want to lose more people like Trisha and Ann and Jody and everybody. So how do we help Trisha? How do we help make our systems better in caring for each other?
Well, and I think we, I think Trisha's going to be staying. I think she's just voicing this, and it is scary to hear, right? But we need to be able to voice this safely and know that people aren't going to put bubble wrap around us. But I think it's working extra hard on connecting when you can, and sometimes meeting, crossing paths when we're faxing something and we end up in the office, and spend a little extra time 6 feet away with our masks on and talking. And taking care of each other. And I know that we've, all groups are working hard at trying to do that and being creative, even sending a text of how you doing today, thinking of you, or be careful, it's slippery out there. But I think that knowing we're not alone, and making sure that we stay connected, and on those days when we want to just cash it in and sell purses at Macy's, to connect and talk to someone. Because I think she is voicing something that we've all felt. I mean, I don't want to speak for Trisha, but I work closely with her, and it's the hard truth right now.
Right. Absolutely. Thank you, Anne and Jim. Jody, let's try you again, my dear.
Yeah, thank you. I had my Zoom screen pulled down because I wanted to show what was behind it, and I couldn't get to my unmute button there initially. But what I wanted to share is exactly answering what this question is that's on the table. What are we doing to try to address this, bigness and ongoing situation that we're all dealing with? And one of the things that we have as an organization have done that I hope and think has been helpful to help support and connect our volunteers who are committed with their compassionate heart and all that they have done to train to serve others. And that is through educational programs that we're offering online. And we have a new series coming right up starting on Monday. And ironically, this one is about addressing and supporting those of us who are serving others by acknowledging and giving tips about how to handle those. Our own Patty Bergstrom, who's an LCSW provider through the Northern Light system in Blue Hill, and a board member of ours, will present on the topic with information, tips, and supportive sharing about how we are juggling many losses along with those for whom we are providing support. So, and then there are 4 more programs coming up in the series. I'd be happy to share that information through Catherine if anybody is interested. They're all being offered over Zoom, so you're welcome. They're all free of charge. You're welcome to attend. But that's one thing that we're trying to do, is to keep people connected, even if it is just virtually at this point, our servers, those who are serving and caring for others. So thanks.
Thanks, Jody. We'd be glad to receive any information posted on our website for you, my dear, always. Yeah, always. Other questions? I have a question for everyone. I haven't heard folks, when you're talking about where you go to get some peace for yourself, it's been briefly mentioned, but not a lot. Some of us find our sort of spiritual center out in the woods and outside in nature, wherever that takes us. Is anybody sort of able to rely on that as a balm for your soul during these pandemic times?
Yeah, if I could speak up, definitely, Candace, thanks for bringing that up, because that's how I get my healing, is out in nature. And of course, this time of year is difficult for me because I don't like the cold. But I wanted to share that my husband contracted COVID from his boss. Fortunately, he didn't need hospitalization, but we had to quarantine him in our bedroom, which means I slept on the couch. And I did everything for him other than use the bathroom. And I found myself stepping out on my back deck, listening to the birds song, feeding the birds, watching the squirrels. It just taking that moment to go out there and do that helped me to strengthen my inner self so that I could continue to care for him and to continue to work and what have you. So yeah, thank you, Candace, for bringing that up.
Oh, you're welcome, Catherine. You're welcome. Catherine Thompson, we'd love to hear from you.
I live on Mount Desert Island, and I look across to Goose Cove. If I look out my window to my right. So I live among the deer, the fox, a porcupine, the occasional skunk. And one of the things that I've been doing is chasing the sunset. Every night at sunset, I go out and take photographs and I send them to friends. And it's been my mental health, keeping my mental health, I think, stable, because I live alone. And it's really been helpful.
Yeah. And you bring up a couple really good points, Catherine. One is the isolation that people who live alone can easily slip into in a more intense place than maybe the busyness they kept themselves out in the world with their networks and social activities. But also the soothing, again, balm that animals give us, and watching animals and talking to animals, if that's what you do. You might not want to admit it, but I do it. So I'm going to offer you the opportunity to say it too, because I think animals sometimes, I realized long ago, they're more all-knowing than we are most of the time anyway. So there's something very comforting about that for me anyway. So many aspects of nature, and of course the glorious sunsets and sunrises, I can appreciate what you're saying, my dear. Thank you very much. Something so simple, really, right? Doesn't cost a thing. Others.
I've learned to speak Labradorian. It's really nice.
You might want to explain that to everybody, Bob.
Oh, yeah. Well, I have a black lab, Gracie, and she's really a human wrapped in fur, really.
Right.
She knows when you're sad. She knows when you're happy. And and she greets everybody with a wagging tail. And it's too bad during COVID, we didn't have tails, at least, that we could wag when we meet somebody.
Yeah, yeah. Yeah, animals offer us so much comfort.
Yeah.
Absolutely. Jim, where would you like to go in the few minutes we have left? I want to give you the freedom to pick these last 10 minutes up. And
I want people to give me more ideas on how to keep putting one foot in front of the other. I've heard some great things.
I see that Paul had his hand up. Paul, would you like to share?
Sure. One of the things, just more of a general nature, but I just wanted to pass on, I'm the president of the board of Down East Hospice Volunteers. I'm also a volunteer, and I'm finding this, in particularly this morning, the value in the hints that I'm hearing and things that I can pass on to caregivers. And I'm hoping with the recording that we can get our volunteers to watch this is also because there's taking or extending care to caregivers right now is a big part of all of this. And I think this is certainly a resource to be able to do that.
Thank you, Paul. Thanks very much. Nice to have you with us as always. Christine.
Yes, hi. I'm driving, so sorry I don't have my video on, but I am a licensed clinical social worker. I work with St. Joseph's Hospice, and I'm a volunteer actually for Eastern Maine Hospice. And I wanted to really acknowledge what Tricia said and the isolation I think as providers or social workers out in the community feel or have felt, because we're not seeing other people. We're not able to kind of debrief just naturally the way you typically would when you're crossing paths or doing joint visits with folks. Also, I've just found that the collaboration I have felt with families, with caregivers in the home has really kept me, I think, more positive and feeling more connected. Still maintaining boundaries, of course, but just shifting my perspective that it's not my coworker necessarily that is my collaborator or through this pandemic, but it's these families, it's these patients, it's folks through churches that I reach out to also offer support to families. I also, just in terms of self-care, I certainly practice gratitude. I certainly exercise routinely. I've been able to really maintain that connectedness with people from a fitness standpoint. And also, staying active. I sing in my church, sing at funerals, stay connected with funeral folks. So I think it's really changing your mindset and being creative and practicing gratitude and maybe redefining some of that connectedness. And it's been surprising, I think. So I guess I challenge folks to look for some unexpected connections and gifts that I think we receive even during these most difficult times, while also really acknowledging and validating how difficult it's been.
Thank you, Christine. Thank you very much. I'd like to go back to the speakers now and ask Bob and Bernard and Jim and Heather, if she's still with us, to maybe make a final comment that you'd like to leave folks with. We have about 5 minutes left.
I'd be happy to jump in. I'd love to go first on this sort of thing, because if I wait and let Bob and Bernard and Heather go first, I won't have anything left to say. I think these are incredibly challenging times for all of us, personally, professionally. I think, I'd like to echo what was just said. I think that maintaining human connection is the challenge. I think that we are, as Candace pointed out, we are social beings. And again, particularly, I think the people that are drawn to this kind of work rely and count on more social connection. And so I think our challenge, or my challenge as I look at this, is to maintain my humanity and my connection and find ways to stay connected to everyone around me, whether it's my patient or my patient's family or my coworkers or my family, my friends. And it's a tough time to do that. And so, I love hearing things from different people today. If any of you come up with newer or better ideas, put them out there for the world, because I think we all need every hint and opportunity to try to find new ways. And I think what Bernard said was incredibly important. We're not going to go back to where we were before, ever. It's going to be a new reality, and we human beings hate change, and we're going to have to find a way to change and continue to thrive in that change. And so my thanks to everyone. It was a delight to hear from so many people. And it's a delight to know that sadly, we're all in this together, but we're all together.
Mhm. Yeah, thank you, Jim. Thank you. Bernard.
Yes. First, I'd like to jump in with a shameless plug. I know I was introduced, but I am also a certified clinical pastoral education educator. When I came to Eastern Maine, I started the chaplaincy training program for spiritual care there. And if anyone is interested, or you know of anyone that's interested in learning spiritual care, they can contact me. And I believe Candace said that they have my contact information somewhere.
Yes. Yeah.
But feel free. So shameless plug. And again, to echo what Dr. V just said, things are not going to go back to normal. It's okay to not be okay, but don't get stuck there. So whatever that means for you and whatever you have to do to get out of that place, explore and find out what works for you in this season that we're in.
Thank you, Reverend Richardson. I'm sure you'll hear from people. You'll certainly hear from us again. Truly, I appreciate, and I know Jody's shaking her head up and down, so she'll be in touch with you. But thank you so much for what you bring to the state of Maine. I truly appreciate it. Thank you. Dr. Bach, a couple words from you.
Bob, Dr. Bob.
Bob, are you with us?
I was muted. I just have to say that Bernard's a real educator and the students just love him. And so this is going to be great for our future because his students would go around and listen to patients. And that's what's going to make the difference, because it's all about relationships. And if we have help in relating to a patient when he's in her in the hospital, that will be progress.
Yeah, for sure. For you, sure. Is Heather? Thank you, Bob. Is Heather still with us?
No, I don't believe so, Candy.
Okay, I think she told me she had to leave because of her duties. I would just then, any final comment from anyone before I make one final comment and we say goodbye?
Well, just that Jim is a blessing.
Yeah, he certainly is. So are you, Bob. And obviously, so is Bernard. I'd like to thank Catherine Randall for the technical side of our support. I don't know what I'd do without her, to tell you the truth, because that's not my strong suit. And I'd like to thank all of you for taking 3 hours out of your day, out of your morning to be with us. Your thoughts mean so much, but they are so meaningful to all who were present. So I think we need to remind ourselves that, yes, maybe some of us physically reside alone in our homes, but we are social human beings. We need each other. We need to regain our value of community. And what I heard, as others did on this call this morning, is all of those of us who were together this morning created a community. of people who are concerned, who are caring, who want to learn, do things maybe a bit more creatively or a little bit differently as they listen to others. And if we walk away with nothing else other than a renewed sense of community, that is something we can pass along to those who weren't able to be with us. And I know many of you, and you do it on a daily basis, but I say, continue as long as you are able to do so, because without community, we are all going to be lost. And I hope the other thought that we take with us is our awareness that we are all human beings first, no matter what professional hat we have on our heads. And we need to respect and appreciate that in each other. So thank you very much. Please get in touch with us if you have further comments when you get off the call. Thank you to everyone. Stay safe. Do good work. Love each other. Thank you.
Thank you.
Thank you.
To everyone.
Thanks to all.
Thanks, Catherine, and thanks, Candace. Thank you.
You're welcome. Goodbye.